glad to be here to do this presentation to talk about microperimetry, which I think is a very important tool and is going to be an increasingly important, vital tool for clinical care, but research as well. Okay, these are my disclosures. And so I want to first start with, I guess, the basics of what is microperimetry. This is really, again, especially how it differs from standard perimetry, because this is really about measuring the retinal sensitivity simultaneously while imaging the fundus. And what that means is you're precisely tracking where the information is coming from, which is quite a big difference from how standard perimetry is done. And it's very useful in the setting of retinal diseases, and we've used it very well and to great effect just in the clinical care of patients in explaining patient symptoms. Sometimes patients complain of small scotomas. You're wondering, why is that? And you're actually able to specifically identify that. It's a paper we published some years ago about actually localizing a particular patient's problem. This particular patient turned out to have a variant of AMN. But my point is, we can explain unexplained vision loss. Another thing that's very useful is going to be increasingly useful, I believe, in the context of future therapeutics like stem cell therapies and the like that are emerging, is actually characterizing the location and stability of fixation. Sometimes you have patients who suddenly worsen, and you're wondering, why do they suddenly get worse? And it's because they lost a couple of photoreceptors and their fixation completely shifted, or maybe it became unstable. And all these little green dots are sort of essentially tests of the patient's fixation stability, how it's moving around, where it's located, and that can be very helpful. And also with new therapies like stem cells that are emerging, that are in trials, you're looking to see, does the fixation move, for example, to where the stem cells are placed? That can give you evidence of how the treatment is working. So that's going to be a very useful aspect as well. And so this fixation testing is a very simple test, and then we're going to get used to parameters like this BCEA, which is the area of this that's spanned by the fixation. Those are all things to look forward to in the future. And then the other thing, which I'm going to spend most of the time on, is mapping the progression of disease. And this is where it's especially being used in clinical practice and clinical research now, by actually measuring the actual sensitivity of the retina in different locations. This is a rapidly growing field. Just you can see, these are publications, and you can see the trajectory. There's obviously more than 1,600 publications on microperimetry, which shows you it's really a topic of great interest, but one of great relevance now. So why has it taken off so dramatically? Because I think we can intuitively understand why it's useful. And part of the reason is because visual acuity, while it's the quick and dirty test that we've used in the office for many years, it's pretty inadequate as a great test of function in many degenerative diseases. Because in many of those diseases, the fovea is spared until very late. And you got to remember that acuity is coming from the foveal cones. And so BCVA just may not detect this progression early enough for us, for patients. And for example, even though many of you have heard of using structural endpoints and OCT, like the status of the EZ, the reality, and we believe that regulatory agencies will consider those things, we know that that's not going to be enough. You have to show a functional benefit, especially for the EMA, for example, and that's why we need to have reliable functional endpoints. So if visual acuity is not going to do it, what are our alternatives? And that's what I want to focus on, because there are a few different alternatives that people have proposed. They're sort of listed here in addition to microperimetry. Low luminous visual acuity, for example, has gotten a lot of press. But the problem is that those are still pretty blunt tools. The real advantage of microperimetry, it's highly sensitive for changes. And there have been some studies that have suggested low luminous really wasn't much better than best corrected visual acuity. And that's, again, the critical thing. Can you detect whether a disease is actually changing? And that's where we think microperimetry is going to be really quite critical. This is just a study of patients with intermediate AMD showing that as the disease progressed from early intermediate AMD to more advanced intermediate AMD, this was mirrored by a loss of sensitivity over time. We did this through the Reimer group. This was a paper that we had been involved in, where we looked at eyes with different stages of AMD, and you can see a nice relationship between the MAIA microperimetric sensitivity and the loss or the progression of the disease over time. So these patients didn't have any change in their acuity. So it just shows you that when we're checking patients' acuity in the clinic, we're missing a lot of relevant information for what's actually happening to those patients. You can actually do more with microperimetry. You can actually, not only does the microperimetry globally seem to get worse in patients, it can more focally get worse over specific areas like bad lesions, like over drusen and the like. And we've shown in these kinds of studies that if we specifically test over individual lesions, this is actually a test over patients with different stages, patients who have early atrophy versus late atrophy. Again, you see that progression. But really the point I want to make is if you look at individual features, this is too small to read in the back, but basically we're talking about different sizes of drusen, vitelliform lesions, drusen that have pigment migration. And what you can see is microperimetry really tracks along the severity of the lesions. It really shows you how good it is at actually showing us functionally what's happening in these locations. So you can do these kinds of very detailed analyses over specific lesions, and you can actually judge what's a worse lesion. We're trying to figure out how we're going to stage intermediate AMD. What is a bad feature? It turns out that specific features like thick basal laminar deposit, hyperreflective foci, the sensitivity can be quite reduced in those areas. And sorry, this came out in black there. But those, it just shows you that not all parts of the retina, even in a patient with AMD, are the same. And we're actually able to see that now using microperimetry. And so again, this is just another case to highlight the limitations of vision, visual acuity. You can see this patient's geographic atrophy can continuously progress. You can see they're missing all of these areas where they can't see, but the acuity is not changing. And so it's a very misleading representation of this patient's image, of the patient's situation. So I want to share with you a personal experience. This was from a trial that we did in collaboration with NIH, and most people won't remember this because this was many years ago, and this was a topical therapy for AMD. And the primary outcome was visual acuity, and it looked like in this trial that the sham group is the white, and the sham group's getting worse, and the treatment group looks like it's doing great. Their vision is stable. Wow, we can just take an eye drop and solve AMD. Well, it turns out when you looked at the the autofluorescence, the lesions were growing quite extensively, so the treatment wasn't actually working at all. There's no difference between the treatment and the patient, just happened to be the exact position of the lesions, and that was reflected in the microperimetry. The microperimetry also showed no benefit of this treatment. So the microperimetry actually reflected what was happening in the treatment, and we would have missed in the completely opposite direction. We would have thought this treatment worked for vision when it actually wasn't doing anything for these patients. So that's why you really need to have a functional test, but you need to have a functional test that actually tells you what's happening with the disease. And we were able to define things like the increase in scotomatous points over time and the loss of sensitivity with time in this study, and even map, for example, the rate of change. So we actually have data on GA lesions, what the rate of change in sensitivity and scotoma are over time. And of course, this is why we use this in clinical trials. Microperimetry was a key part of the phase 3 trials of lampalizumab. And it was interesting, this is a therapy that obviously didn't work. You can see both the treated and untreated arms both show progression of the GA, but we also saw this very well reflected in the microperimetry. In terms of the number of scotomatous points, also matched it very well. Microperimetry really seems to match structure very well in these retinal degenerative conditions, and it really clearly is a better tool than acuity for this type of testing. It's also been critical in studies of the new agents like the complement inhibitors, where there was a reduction in GA growth, but you couldn't see it in acuity because it depends on where the lesion is. And of course, when microperimetric analysis was done, you could actually see that there was actually preservation of function that was observable by looking at the microperimetric sensitivity. Look at these this further loss of sensitivity in untreated patients compared to the treated patients. So again, that's why it's a really critical tool. Now, we've done things like studying the sensitivity around the GA lesion, and actually in some GA lesions you can find reduced sensitivity around the lesion, which actually corresponds to photoreceptor loss around the lesion, which may highlight patients who are more susceptible for disease progression. And I just wanted to highlight, though, that it's not, I've said a lot about GA because that's where a lot of the research is. That's where we're using it clinically in many patients, but it's not just for patients with GA. It's very relevant to a whole host of different retinal diseases. I think for just about any retinal disease, but certainly for retinal degenerative diseases, as shown in these examples. Sorry for the blurry plot, but this is just a paper that we'd published showing even in diabetic retinopathy and diabetic macular edema, the relationship between the cystoid space volume and the retinal sensitivity. So the more cystoid spaces you have, the worse the sensitivity. That kind of makes sense because patients who have severe cystoid edema, the Mueller cells are injured. It's not surprising that there's some functional deficit in those patients. It's sorry that it's appearing blurry, but this was actually even a study we did looking at aquaplasmin for vitreomacular interface disease. Obviously, this is off the market now, but we were able to show that even though there was concerns about photoreceptor injury from aquaplasmin, actually the sensitivity was relatively preserved in these patients. So I didn't want to make this seem like it's all, like all perfect. There's no challenges. There's obviously room for improvement because there are some cons. I mean, why don't we use this for every patient? Well, it takes time to do the testing. Some patients have such poor fixation, they have trouble doing the testing. And a patient has to sit there and do that. So they have to be compliant with that testing despite all of these great benefits. So really what we'd like to see is to make this test a bit faster and easier for us by increasing automation, having better tracking to deal with fixation and stability, and maybe we could shorten the test time if we can do more customized patterns. And that's what's exciting. I just wanted to say a few words about solutions for this, and we're very, very grateful to iCare for introducing and bringing in, sort of ushering in this next generation of microperimetry. Because what's really cool about the new device is an active retinal tracker. I can tell you that's vital for being confident and not only knowing where you're testing, but also in completing the test on some of these patients who don't have good fixation. The confocal technology gives us much better fundus imaging, and with good tracking and a good fundus image, you can do much more reliable longitudinal testing over time. So again, it's really nice that you're doing real-time tracking, so you can track the patient's movement. Having the confocal true color image, that's hugely valuable, especially if you're studying lesions or diseases like AMD, where the atrophy is actually well visualized and you actually can see the borders. We've published that using, and this is with the AIDEN system, but the same point, using confocal color, that we could get as good delineation of atrophy on that as compared to autofluorescence. And as I said, when you have a high quality confocal fundus image and you've got really good tracking, then you really can monitor progression over time. And it's especially important because sometimes these patients preferred retinal, we call this a preferred retinal locus, which is their fixation point. Sometimes it can change in these GA patients. And even though it's changed, you're able to then actually map the retina and make sure you're still testing the same location, which is super vital to actually get data that you can believe. So it's not a trivial advance. It's a big advance to be able to have this type of precision. And of course, it's still backwards compatible to the older systems, which is pretty vital because sometimes we've collected the data on second generation MAIA, for example. And also, of course, it offers a bigger field of view. And I talked about how this is not just GA, it's also testing other retinal generations like RP. So having a bigger area of coverage and to be able to test those areas is important. And of course, one of the great things about the devices on the iCare platforms in general is that they're pretty automated, right? So the fact that they get the patient in position and can run the test with auto alignment means that you don't need to train your staff a lot, right? I'm not saying a monkey can operate it, but almost a monkey can operate it, which is pretty important because we don't necessarily always have the staff to do testing that would otherwise be more complicated. So that's pretty important. And the last thing I'd mention is now we can do much more customized tests because that's how you shorten the testing time to test the areas that you care about to actually make this practical to do in more patients. So that's pretty huge as well. So I just would close with the comment that it's clearly, we've done most of our research in AMD, but I highlighted some of the other papers we published. It's useful across retinal diseases. It gives us a new insight on a research perspective into what's happening with the diseases, but I think it's useful for clinical practice, and actually it's about making the tool practical for clinical practice, and that's where I think the next generation devices are going to be so impactful. So with that, I'm going to stop, and thanks very much for those of you who stuck around. Thank you for that. Yeah, the question was about whether I talked about some of the complement therapies and how microperimetry is useful. So the question was about photobiomodulation and could this be useful? So of course, I gave a talk about photobiomodulation and said that we probably need more studies to be confident that it works. But microperimetry could be hugely valuable in helping us understand whether it works and how it's working, right? So for example, if you do sensitivity testing over drusen, and you see that the sensitivity is reduced over the drusen, then you treat a patient, you see the drusen go away and the sensitivity improves, that could be some evidence that there's been some impact. I'd want to test areas with the drusen has gone away, as well as areas where maybe the drusen hasn't changed to see if there's a benefit. So I think that that microperimetry would give us much more confidence on whether we're achieving something with the treatment. I would believe that a lot more even than some of the visual acuity data. So I think it's a great point.